Hello, everyone. Welcome to our webinar on Section 1115 Demonstration Waivers, a primer to the upcoming A New Way Home, Medicaid and Reentry Symposium on April 1st, hosted by the Center for Health Law and Policy Innovation. My name is Medha, and I am a Master of Science student at the Harvard Chan School of Public Health, as well as a clinic student at the Center for Health Law and Policy Innovation.
Hi, everyone. I'm Sophia, and I'm excited to join Medha as your co-host for today's webinar. Like Medha, I'm also a clinic student at the Center for Health Law and Policy Innovation, as well as a Master of Public Health and fourth-year medical student.
At the Center for Health Law and Policy Innovation, we monitor and analyze health law and policy proposals and assess their likely impact, particularly on systemically marginalized communities and people living with chronic illnesses. One of our roles as clinic students is to collaborate with our team and stakeholders to develop advocacy materials. Today, we will cover ways that Medicaid reentry waivers can strengthen reentry support and provide crucial healthcare services for individuals transitioning from incarceration. These Medicaid waivers offer exciting opportunities for successful reentry of justice-involved individuals and overall community well-being. So to get us started, here is an overview of our presentation agenda outlining the key topics that we'll be exploring in depth today. During this presentation, we will cover the background of incarceration and public health implications in the United States, followed by a discussion of Medicaid waivers and their uses for reentry. We will then provide a comparison of different states applying these waivers within their populations, along with a high-level overview of the waiver submission and approval process. To wrap up, we will then highlight ways for you to get involved as an advocate. By the end of this presentation, it's our goal that you are able to know what a Medicaid Section 1115 waiver is and understand its uses. Understand the reentry waiver purpose and components. Consider current approaches states use to develop these waivers and ways that advocates can get involved. To contextualize our discussion today, it's crucial to first examine the background of mass incarceration and its profound public health implications in the United States. The US has the highest incarceration rate of any country in the world, holding 1 out of every 5 prisoners globally. Of those incarcerated, certain populations are drastically overrepresented, including racial and ethnic minority populations. A recent report by the Prison Policy Initiative shows that although the Black population makes up only 14% of US residents, they represent 42% of individuals in correctional facilities. This stark disparity is largely attributed to historical and political factors, including disinvestment in Black communities and disproportionate policing practices. Historically marginalized communities and those with mental health conditions and substance use disorders are also uniquely affected by incarceration. Nearly 2 million people with a mental illness are jailed annually, and a staggering 68% of the jail population meets the diagnostic criteria for substance use disorder. When we think about the impact of incarceration, we must consider that the experience itself is associated with poor health outcomes. Individuals within incarceration exhibit elevated rates of various health conditions, including high blood pressure, cancer, asthma, arthritis, and infectious diseases such as tuberculosis, hepatitis C, and HIV when compared to the general population. This disparity may stem partly from the significant barriers to healthcare encountered prior to incarceration. Additionally, inadequate healthcare within correctional facilities has also been linked to exacerbated health conditions, such as heightened mortality rates among individuals with cancer and worsened mental health symptoms. A recent study also shows incarceration increased the risk for premature death due to infectious disease, chronic lower respiratory disease, drug use, and suicide. Deficient care, both before and during periods of incarceration, leaves many with complex medical needs requiring long-term management. The Section 1115 reentry waiver offers a promising opportunity to address these health disparities and improve access to care for people returning home. Now that we have a better understanding of incarceration in the United States, let's explore Medicaid and the basics of Section 1115 demonstration waivers. Medicaid is a joint state and federal entitlement program that covers health and long-term care for eligible individuals and families with low income. Each state has a state Medicaid agency that is overseen at the federal level by the Center for Medicare and Medicaid Services. Also, for the purposes of this presentation, we'll refer to the Center for Medicare and Medicaid Services as CMS. CHIP is a similar program that covers low-income children who live in households that make too much money to qualify for Medicaid. Medicaid coverage can vary by state, but there are certain services required by law to be covered everywhere, including prescription drugs and hospice, among others. States have the flexibility to design their Medicaid programs within federal guidelines set by CMS to meet the unique needs of their populations. The Section 1115 demonstrations, also known simply as waivers, allow states to implement and evaluate state-specific policy approaches to better tailor programs addressing the healthcare needs of their communities. Examples of how states have previously implemented these waivers, including during natural disasters and public health emergencies such as COVID-19 and the clean water crisis in Flint, Michigan. Recently, these waivers have been used to pilot food-based initiatives addressing health outcomes and disparities in food insecurity and nutrition. Building on our understanding, let's discuss the rationale behind applying for Medicaid Section 1115 reentry waivers, which we will refer to throughout this presentation simply as Medicaid reentry waivers. As previously discussed, incarceration negatively impacts an individual's health and may worsen existing health conditions, leaving many within the system with complex health needs. One of the ways periods of incarceration lead to poor health outcomes is due to the effects of the Medicaid inmate exclusion policy, which is a restriction that prohibits Medicaid from covering services for individuals who are incarcerated, except in some very specific instances of inpatient care. While someone is incarcerated, their health care is therefore provided by the facility in which they are held without any financial assistance from Medicaid. The burden of absorbing healthcare costs can lead to a lack of quality care, directly contributing to the poor health outcomes we just discussed. Additionally, the Medicaid inmate exclusion policy also leads to delays and disruptions in care. As in some states, Medicaid coverage is terminated when an individual is booked into a facility, requiring them to reapply upon release and wait to be reapproved. During this process, which can take up to several weeks, these individuals are without healthcare coverage, preventing them from accessing necessary care and medication. Imagine the impact this has on people with chronic conditions such as HIV. These disruptions can have dramatic impacts on health and even be life-threatening. The purpose of Medicaid reentry waivers is to partially repeal the Medicaid inmate exclusion policy, allowing for Medicaid to cover pre-release health and social services prior to an individual returning home. These waivers offer an exciting opportunity to improve access to care for individuals who are incarcerated both during the pre-release timeframe and after, helping to promote continuity of care and address health disparities. We will now outline the key goals and objectives associated with implementing reentry waivers. CMS defines 6 main goals to these waivers, including increasing insurance coverage, improving access to health and reentry services, reducing the number of emergency department visits and hospitalizations post-release, increasing investments in healthcare and related services, improving connections between carceral facilities and community services, and reducing the number of deaths of individuals returning home after incarceration. Transitioning to the current landscape, let's explore which states have approved and pending waivers. On this map, we can see that states coded in red have approved waivers, and states coded in pink have pending waivers. You can monitor the status of these waivers using the Kaiser Family Foundation Waiver Tracker. A QR code for this tracker is located in the resource toolkit at the end of the presentation. So far, 3 states' waivers have been approved by the CMS, and there are currently 18 states with pending reentry waivers. Later in the presentation, we will discuss and compare the various reentry waiver components of the states with approved waivers, including California, Washington, and Montana, to demonstrate the different ways these states have designed their waivers. Now that we've identified the states that have waivers, let's shift our focus to the essential components of a reentry waiver. When designing a waiver, states should answer the following questions, including: who will be eligible for pre-release services? How soon before release will these services be provided? Which facilities will provide these services? What services will be provided in addition to the pre-release services required by CMS? And finally, who will be providing these services? States have a lot of flexibility to customize the components of their reentry waivers to suit the specific needs of their communities, allowing them to address unique challenges and implement tailored solutions. Having covered the main components of Medicaid reentry waivers, we will now review the guidelines provided by the CMS for these different components. These are the minimum set of services states must include in their waiver application for waivers to be approved. These services are essentially the floor set out by CMS, and states must meet this floor, but they also have the discretion to add additional services to their pre-release packages. The 4 major components of these waivers are outlined here. First, for eligible individuals, beneficiaries of the pre-release services include individuals who are Medicaid eligible and within the pre-release timeframe. We will discuss the details of the pre-release timeframe later in this presentation. CMS has given states the authority to include all Medicaid eligible individuals or to target populations, such as those with certain medical conditions. If states plan to narrow the eligibility criteria from all eligible individuals to specific demographics, they must organize a screening process to identify beneficiaries. Also, considering that Medicaid is connected to CHIP, states need to determine whether or not CHIP populations will be included in their eligibility criteria. Second, considering eligible facilities, states can determine which facilities should implement these waivers, including state prisons, local jails, and/or youth correctional facilities. Considering what facilities will participate in the reentry waiver, states may provide services in all eligible correctional facilities statewide, or they can choose to only provide services in a subset of correctional facilities. States may also include a phased approach in which they start with one type of setting at first and later implement at other sites. Of note, CMS has excluded federal prisons from participation. However, states may include individuals in federal prisons in the reentry waiver to help federal prisoners submit Medicaid applications. Third, under covered services, there are 3 benefits CMS outlines as the minimum criteria states must include in their reentry waiver for approval. These benefits include case management services, medication-assisted treatment or MAT, coverage for counseling, and a 30-day supply of all prescription medication at the time of release. We will discuss these covered services further on the next slide. Finally, we have the pre-release timeframe. The pre-release timeframe for incarcerated individuals refers to the period of time before their scheduled release from incarceration. During this time, various reentry services and programs may be provided to help prepare individuals for their transition back into the community. CMS allows states to define their individual pre-release timeframe within the bounds of 30 to 90 days to allow for sufficient time in transitioning care. Now we will continue with a more in-depth discussion about the services covered under reentry waivers, what they include, and their benefits. The first required service is case management. Case management helps ensure a successful transition for individuals returning home by facilitating connection to services that assess and meet an individual's health needs, including behavioral health needs and health-related social needs. Case management includes several important activities, including comprehensive medical assessment, care plan development, referrals, and care coordination, and monitoring and follow-up. According to the CMS, the care plan developed for the individual may include the full array of Medicaid covered services and supports, including health supplies and appliances they may need upon release, such as a wheelchair, a walker, and a glucose meter. The second required service is medication-assisted treatment and counseling. Medication-assisted treatment includes coverage for mental health counseling and FDA-approved substance use disorder medications, including those of opioid and alcohol use disorder. Medication-assisted treatment is important to improve mental health outcomes and support individuals in achieving and maintaining long-term recovery from substance use disorder. Providing medications for addiction treatment pre-release also reduces risk of relapse and death during incarceration and post-release. The third required service is a 30-day supply of medications. A 30-day supply of treatment ensures that individuals have uninterrupted supply of medications immediately upon release. This reduces the risk of disruptions in the care plans established during incarceration. This also provides individuals with a period of stability as they transition back into the community. Now that we've covered the purpose and goals of reentry waivers, as well as their different components, Sophia will continue with the rest of the presentation.
Thank you, Maida. Now that we have a comprehensive understanding of the key components involved in Medicaid reentry waivers, we would like to highlight the discretion states have in designing their waivers by comparing components of the 3 states' waivers that have already been approved. We will begin by discussing individual eligibility criteria. As we discussed earlier, states have a lot of flexibility in deciding who will be able to receive pre-release services, and looking at these states, you can see they each have a different approach. Washington included all Medicaid eligible youth and adults. Like Washington, California has decided to include all Medicaid eligible youth. However, they have targeted the adult population by only allowing people with a qualifying condition to receive services. Montana, on the other hand, has the most narrow eligibility criteria, only including people with a mental health condition or substance use disorder. Washington's broad approach to eligibility may help address health, mental health, and health-related social needs for people who do not have a formal diagnosis or who may have unmet needs. Additionally, it may prove to be more efficient as it will not require an in-depth screening process to identify individuals with qualifying conditions. Narrow eligibility criteria does require screening and risks excluding individuals with undiagnosed health conditions or other unaddressed needs. Later, we will review 2 case scenarios that highlight the importance of having broad criteria to achieve waiver goals and drive down disparities. Moving on from eligibility criteria, let's compare some state examples for facility criteria. Here we can see that California and Washington have chosen to implement pre-release services in all eligible facilities throughout the state, while Montana has a much more limited approach, with only state prisons participating, which may limit the impact of the waiver. For instance, people enter jails at a higher rate than prisons. In 2022, nearly 500,000 people entered prison, but individuals were booked into jail over 7 million times. This represents a significant number of individuals exposed to the harms of incarceration and at risk of losing their healthcare coverage. Including broad eligibility criteria is beneficial to maximize the potential impact of these waivers. Building on our understanding of eligibility and facility criteria, let's now compare state examples for covered services, highlighting the range of benefits each state has chosen to provide. As mentioned earlier, in addition to the minimum services mandated by CMS, states have the flexibility to include additional benefits in their waivers. As you can see, each of these states has uniquely tailored the package of services provided. For example, California includes the most expansive set, encompassing additional pre-release and post-release services, such as lab and radiology tests and durable medical equipment. Similarly, Washington has chosen to go beyond the minimum set of services, offering support for individuals with complex needs. On the other hand, Montana has a more narrow package that closely resembles the minimum requirements CMS has put into place. Concluding our exploration of state approaches to reentry waivers, let's now discuss the pre-release timeframe, which refers to the period before an individual's release, during which these pre-release services will be provided. California and Washington have defined the pre-release timeframe as 90 days, the maximum length allowed by CMS. In contrast, Montana has set it at the minimum of 30 days. Returning to our discussion on required services, case management involves assessing an individual's health and social needs and creating a person-centered care plan to address these needs. A longer pre-release timeframe allows for a more comprehensive assessment and provides case managers with more time to connect individuals with community health and support services, improving the likelihood for a better transition. For your reference, here's a summary slide with an overview of the reentry components for the 3 states we covered in this presentation. We will use this information in the following slides. Now that we've examined the various components and criteria of reentry waivers across different states, let's apply our knowledge to a couple of practical scenarios. In these slides, we will discuss 2 individual profiles and analyze their eligibility for pre-release services in the states previously discussed. By doing so, we can get a deeper understanding of how these waivers operate in practice. Our first individual is Sam, who is a Medicaid-eligible 25-year-old incarcerated in a state prison. They have current medical conditions, including a mental health condition, substance use disorder, and they are currently pregnant. Let's consider in which of the 3 states previously discussed, California, Washington, and Montana, would Sam be eligible for pre-release services? Given their medical history and facility type, Sam is eligible for services in all 3 states. In California and Washington, Sam would begin to receive services 90 days before release and just 30 days prior to release if they were located in Montana. Continuing with another scenario, let's discuss Sean. Sean is a Medicaid-eligible 40-year-old incarcerated in a county jail. They do not have substance use disorder or other health conditions. Let's examine in which of the 3 states would Sean be eligible for pre-release services. First, since Sean does not have any medical conditions or substance use disorder, they do not qualify in California or Montana. However, if they did have either of these conditions, they would qualify in California, but not Montana, because they are incarcerated in a county jail and not a state prison. If Sean was in Washington, they would qualify for services because the state has the broadest eligibility criteria, extending pre-release services to all Medicaid-eligible individuals in all facility types. From these examples, we can see how broad eligibility criteria increases the potential impact of these waivers and their ability to address health disparities and improve access to care for people returning home. With a clear understanding of the flexibility states have in designing their waivers, let's navigate through the intricacies of CMS waiver submission and the subsequent approval process. It's important to note that this process is for state Medicaid agencies and not necessarily for advocates, but we wanted to discuss a high-level view of the process for your understanding. However, advocates may participate during this process through notice and comment periods, which we will now cover. The first step of this process includes states developing new waivers with public input through a 30-day notice and comment period. The 30-day comment period provides advocates, stakeholders, and the general public with an opportunity to review proposed waivers and provide feedback. This timeframe allows for a thorough consideration of the proposed changes, potential impacts, and any concerns raised by stakeholders. Additionally, states are required to respond to comments from the public, allowing advocates to gain some understanding of how and why a state has chosen to address certain concerns. Advocates can participate in this comment period by submitting feedback to the state Medicaid agency and engaging in efforts to raise awareness and mobilize community support. You can reach out to your state Medicaid agency to determine if your state is developing a waiver and ask them when the comment period will be. This active involvement allows advocates to influence Medicaid waiver development, promoting transparency and accountability. Step 2. After the 30-day state comment period, applications will be submitted to CMS. If any elements are missing and the application is considered incomplete, CMS will notify the state. Following the state public comment period and CMS submission, there is a 30-day federal comment period that functions similarly to the process outlined at the state level. After the federal comment period, CMS will evaluate comments and decide on the approval or denial of the application. Waivers are usually approved for 5 years, with the possibility of extensions for up to an additional 3 to 5 years, depending on the population served. You can visit the CMS website that we have linked at the end of this presentation for more details. Now that we've covered the submission and approval process, let's discuss the critical phase of developing the reentry implementation plan, which is a detailed summary of how the state plans to provide the reentry services and address foreseen challenges in the process. In basic terms, the waiver application is what states would like to do with the waiver, and the implementation plan is how they plan to do it. In order for states to receive Medicaid funding for the pre-release services, CMS must approve their implementation plan, which is submitted after CMS first approves the state's waiver application. There are a couple of important components to the implementation plan that we will discuss today. First, we'll touch on the waiver milestones in the implementation plan. States must describe how they will achieve the milestones that CMS has defined for effectively implementing these waivers. The first milestone is to increase and maintain Medicaid coverage for individuals when they enter a carceral facility through application, renewal, and suspension processes. Returning to our previous discussion of the effects of the Medicaid inmate exclusion policy, if a person who currently has Medicaid enters a facility, in some states, their Medicaid coverage will be terminated. To fulfill this milestone, states must suspend rather than terminate an individual's coverage to avoid having to re-enroll them once they enter the pre-release timeframe. States must also develop a plan for identifying people who are eligible for Medicaid and enrolling them prior to release. The second milestone is to cover and ensure access to the minimum set of pre-release services to improve care transitions when the individual returns to the community. The third milestone is to promote continuity of care, ensuring that upon release, the individual has timely access to health services and medications. The fourth milestone entails connecting individuals to services and supports to address their health-related social needs, including housing and employment. States must also establish a monitoring process to ensure the individual receives the necessary services post-release. The fifth and final milestone is important to achieve all of the previously discussed milestones. This final milestone requires states to describe how they will ensure there is strong cross-system collaboration between the state Medicaid agency, carceral facilities, and community-based providers and organizations. To promote collaboration, CMS emphasizes the need for monitoring and data sharing between these different stakeholders. Within the implementation plan, another key aspect is determining who will provide the pre-release services. According to CMS, pre-release services can be delivered by in-reach community-based providers, carceral facility providers, or a combination of both. CMS emphasizes that in-reach providers are the preferred choice as they facilitate continuity of care by allowing the provider who will serve the individual after release to begin developing their care plan before returning home. However, CMS acknowledges that in some areas there may be a shortage of health professionals, in which case community-based providers may use technology to conduct telehealth appointments, or carceral facility healthcare staff may provide the pre-release health services. The last required piece of the implementation plan we're going to talk about is the reinvestment plan. Advocates should think of the reinvestment plan as a summary of how states intend to use the savings acquired by Medicaid paying for carceral health services that, without the waiver, the state would have had to pay for. Remember how we discussed that without a waiver, carceral facilities and states bear the burden of financing healthcare services for people who've been incarcerated? Under a reentry waiver, the federal government will pay for the health care for individuals who qualify during the pre-release timeframe, theoretically resulting in savings for the state. The reinvestment plan describes what the states will spend these savings on and is a particularly exciting component of these reentry waivers. It provides states with the opportunity to directly address health disparities by investing in initiatives that increase access to or improve the quality of healthcare for individuals at higher risk of incarceration and those recently released. In fact, savings may also be used to benefit the community at large by funding interventions that address health-related social needs, thereby helping to prevent individuals' involvement with the criminal justice system altogether. According to CMS, the reinvestment plan can be used to fund health-related social services such as improving access to behavioral and physical health services in the community, including mobile crisis services, trained peer supports, and long-term services and supports for individuals with chronic conditions and complex health needs. It may also be used to enhance community-based provider capacity, specifically those tailored to the needs of justice-involved individuals or those at risk of justice involvement. Finally, it may also be used to expand or enhance community-based reentry services and supports. Of note, CMS has made it extremely clear that reinvestment funds may not be used for building new jails or for general facility improvements unless they directly help the healthcare needs of people in incarceration. Through reentry waivers, CMS acknowledges the detrimental health effects of incarceration and emphasizes the importance of addressing these impacts. The reinvestment plan requirements empower states to address poverty, mental health conditions, and substance use disorders more effectively by investing in community resources and improving access to essential care and services. All right, now let's talk about how advocates and other stakeholders can actively get involved in shaping Medicaid reentry waivers. First, it's crucial to do some preliminary research. Take some time to browse the CMS website and check out the Kaiser Family Foundation Section 1115 Waiver Tracker, which, as we mentioned, is located in the Additional Resource section of this presentation. On the website, you'll be able to filter the waivers by Section 1115, as well as those specific to justice-involved individuals. This will give us insight into what's happening in other states and what steps we can potentially take in our own state. Once we understand the landscape, we can identify key stakeholders and state-specific programs by consulting our state health departments. As we mentioned earlier, regarding the CMS submission and approval process, we can keep an eye out for state and federal public comment periods. We need to make sure we're informed about when these periods occur by staying in touch with our state Medicaid agencies. Another way to get involved is by looking for community advisory boards and stakeholder groups. These platforms provide avenues for individuals with lived expertise and community organizations to contribute valuable insights and perspectives. For example, in Massachusetts, there's a Mass Health Advisory Board specifically for people with lived expertise. Engaging with these committees can further amplify our advocacy efforts and ensure that the voices of those directly impacted are heard and considered in the decision-making process. Finally, once the waiver is in motion, we should follow the implementation process closely and participate in stakeholder meetings whenever possible. If you come across any roadblocks or need additional guidance, you can seek out opportunities for technical assistance through organizations such as national advocacy groups and CMS. Our continued engagement is crucial to ensuring that these waivers truly meet the needs of our communities. Okay, let's wrap up our discussion for today. In this presentation, we covered a wide range of topics, including the background of mass incarceration in the United States, the basics of Medicaid and Section 1115 waivers, and the significance and components of reentry waivers. The key takeaway for today is how these reentry waivers offer a unique opportunity for states to tailor healthcare access and reduce disparities among justice-involved individuals and their communities. We encourage everyone to get involved in advocating for reentry waivers in your state to improve access to healthcare and reduce the disparities. Please refer to these additional resources provided that we've referenced throughout our presentation. Here's the Kaiser Family Foundation State Waiver Tracker that we mentioned. You can scan the code and it'll take you directly to their website. Thank you for your attention today. Your interest and support are crucial for advancing efforts to improve health outcomes and reduce disparities in our communities. For further information or inquiries, please contact the Center for Health Law and Policy Innovation.